really happy to be here at CGSI. And that's the truth. Like, I've been coming to CGSI since 2016 when I was still postdoc. And if you look back at the video, I don't, because it's just too cringe-worthy. You can hear me complain about flying with a newborn for like 8 minutes. And now that newborn is 8. And so for me, CGSI is kind of like my birthday, you know, like I get to be with all these people I've grown with over the years and make new friends. At the same time, it's this moment in the middle of summer where you sort of think back, like, what did I do this year? What do I want to do next year? You know, how am I standing in life or in science? And so yeah, it's been a really great week so far. And what I'm going to talk to you about today is just some snippets of information, really, or some observations that we made about using biobanks and using biobanks to study people that are not in it. That will hopefully become clear, although this talk is a little bit of a roller coaster ride. So I hope it's going to work out. But yeah, biobanks, you know, are increasingly popular. We have a whole workshop session on biobanks, and we've learned a lot of amazing things already this week. They allow us to study complex architecture of health and disease. We study disease trajectories, we study comorbidities, and they're really the gateway to precision medicine. You know, some of these, you know, papers have already been shown in this week. You know, they're increasingly used for all kinds of genetic analysis, using, for example, the Global Biobank Meta-Analysis Initiative. Also here at UCLA, we have an amazing biobank called Atlas, which is one of the most diverse biobanks in the world. And biobanks are becoming more common worldwide in different places, not just in the global north. So I study psychiatry. I maybe should have mentioned that instead of talking about that newborn travel adventure. I study psychiatry, psychiatric genetics, and I use a lot of biobanks to ask clinically relevant questions about psychiatry. And so one of the questions that we're interested in, together with my colleague Jeff, I don't know if he's here right now, we try to study perinatal depression. Perinatal depression is depression that happens in mothers with an onset during pregnancy or following childbirth. And it's very common. It happens in about 10 to 20% of mothers. It often starts during pregnancy and then continues. And if it's not treated, it can be really bad for mother as well as for child. And so, you know, because it's overwhelmingly understudied, we study it. And I'm not actually going to talk about this project. I'll just use this as an example. But what we're trying to do in this project is identify at-risk mothers using clinical as well as genetic profiles. We're also trying to understand the etiology of perinatal depression and the genetic relationship between people with perinatal depression and other types of depression. Is that a subtype of depression? Is it different? That is some of the questions that we're trying to figure out. And we're doing this together with Jeff Chang, Varuni Sarwal, as well as Aditya Pimplaskar. And Aditya was looking into the genetics and specifically trying to compare PND, so perinatal depression, to non-PND MDD. And in our initial analysis in Atlas, we compared these different cohorts of individuals. And what he saw was that if we compare perinatal depressed women with women that are depressed in another time in life, actually the perinatal depressed women have a lower MDD polygenic risk score than the other types of depression. And so that was a little bit odd, maybe unexpected to us. And we were wondering, why is this the case? Like, is this different genetic etiology? Or is it maybe something about Atlas? Is it something about how these people come into Atlas that we see this, that sort of leads us to see these patterns. And so this really like unraveled a whole kind of story that I'm going to talk to you about today. But basically, what we then wanted to see is this, how is the representation of women with MDD and PND in our biobank cohort? And what we found was really striking, was that there is a 5-fold overrepresentation of women with MDD in Atlas compared to at UCLA EHR overall. So at UCLA, about 5% of women have MDD, 5 to 10, but in Atlas, it's about 25 to 30%. For PND, we also see an overrepresentation. It's not as extreme, it's about 3-fold. And so then we were wondering, like, whoa, is what we're doing by comparing PND to other MDD in Atlas, is that sort of, are we looking under a lamppost here and not really seeing the whole picture? And because what we want to do is look at the people in the biobank in the context of the health system. What we want to infer is something about, patients seeking care at UCLA. What we even more so want to do, right, is look at the healthcare system in the context of society. And so, for example, in this example, I'm talking about Atlas, which is our biobank, UCLA Health, which is, UCLA Health, and then the society might be LA or California or maybe US, depending on the question that you're asking. And so my talk is about those 3 bowls, really. Both here in LA as well as in Colombia, South America. There's another problem about studying severe mental illness in biobanks. Here I'm talking about schizophrenia and bipolar disorder, because we see that in the EHRs, patients with schizophrenia and with bipolar disorder are actually underrepresented compared to population. And so, for example, here I've put in the numbers that we used for a Psyche Merge grant, where we have 2.2 million people genotyped, but we end up with only 24,000 patients with bipolar disorder and 9,000 patients with schizophrenia, which is about a 2 to 3-fold underrepresentation for schizophrenia, and for bipolar, it's more close to population prevalence. In UK Biobank, the underrepresentation of bipolar disorder and schizophrenia is way, way more severe. Okay, so can we have the cake and eat it too? So can we take advantage of longitudinal EHR of a biobank, but can we have a representative sample, and can we have the sample size for genetic discovery? That's a lot to ask. And I think, I'll leave you to judge whether we can. But where we're doing this is in Colombia, the country. And I talked about this a little bit yesterday in my talk, so you can zone out comfortably if you were there. I will let you know when it's time to get back on board. But in Colombia, there is a region, a Paisa region of Colombia, set between 2 mountain ranges. It's a very beautiful region where the coffee grows. And about 9 million people live there. For our genetic studies, it's very interesting because it is a population isolate. So the population was founded in the 16th, 17th century when the current population was founded, when Spanish came, and it was mostly mating between Spanish males and Native American females that led to initial admixture, and followed by, and these events were followed by several bottlenecks and rapid expansions, and as a result, we have a population isolate similar to Finland or perhaps Pakistan that we can use for genetic studies. And Jaslyn actually wrote one of the first papers showing that this, the extent of this population isolatedness. All right, so in this region, we're building a biobank called Mission Origin, a project that we believe bridges the gap between achieving scale for discovery as well as high quality phenotyping. I talked about the phenotyping yesterday, so I'm not going to talk about it today, but the goal of this project is to include 100,000 individuals, 50,000 patients with severe mental illness, which we broadly define as having a diagnosis of bipolar disorder, schizophrenia, or severe depression, primarily recruited from 3 psychiatric hospitals. For a subcohort of these 50,000, we also have deep phenotypes, such as interviews and cognitive assessments. We're recruiting 50,000 controls. They are recruited from the same region. They are matched based on demographics, geographically, as well as based on education. And they're being recruited through Sura, which is a health insurance and healthcare provider in the region, similar to what we have here, Kaiser, for example. And so all the phenotyping, we can do this at this scale because all the phenotyping will be electronic health records based. We have EHR of over 400,000 psychiatric patients through these hospitals, which is about 4 to 5 times what we, for example, have here at UCLA. We have EHRs. We're screening participants for our projects from about 5 million Sura patients. We're getting genotyping on all these individuals. We're currently using, for the majority of them, blended genome exome, which is a combination of low-pass whole genome sequencing and deep exomes, which is done at the Broad Institute as part of PUMAS, as well as some other projects, which I'm not going to talk about today. Okay, so we're excited about Mission Origin because it can power genetic discovery, not just for diagnosis, but also for symptoms. We are hoping to characterize risk for severe mental illness, the interplay between genetic risk and environmental risk, and of course, perform these longitudinal analyses of disease trajectories, such as diagnostic changes, treatment, response, etc. Okay, but back to the 3 bowls. So here is one of our main recruitment sites, Clínica San Juan de Dios in Manizales. And so in this context, the Mission Origin, MO participants are our biobank participants. The clinic is the green bowl, and Caldas, which is the state in which this hospital is located, and in fact, this is a kind of unique hospital because it's the only psychiatric hospital that provides treatment to patients with mental illness. So it serves all the inhabitants of Caldas. And so first thing that we wanted to look at, are these study participants representative of those receiving care? Are the people that are included in our study representative of those that could have been recruited? And so we compare our cohort to the people that could have been recruited but weren't because we have their EHR. And we compare, for example, the rate of suicide attempt here shown in these individuals. And it looks pretty similar. And overall, if we look at these are different features that we extract from the clinical notes, it looks very similar for those that were recruited and those that weren't. And we looked at a whole range of other features too, such as diagnoses, healthcare use, family history, and substance use information. And overall, we can say, yeah, what we're seeing in the people that are recruited are similar to those that chose not to be included or maybe weren't reached for by our study team. Okay, so now we get to the second comparison of how does the hospital actually serve the population that it is meant to serve. So in another way of saying that, is care accessible to all the people in the state? And so we're interested in looking at these barriers for seeking treatment, and Janet Song was the first student to really dig into this, and what she did was look at the relationship with travel time as a first barrier to seeking care. And so what we asked was, if you have to drive longer, if you have to travel longer to get to the hospital, is that a barrier to actually making it, to getting the care that you need? And so we did this, and what we found was that the answer is yes and no. For inpatients, we basically see that if somebody needs to be hospitalized, regardless for how long they have to travel, this map, by the way, shows travel time, hours of travel from the clinic, which is that sort of white spot. So some people really need to travel upwards of 5 hours. By the way, just a side note, that bus that goes to Temescal is really good. My kids take that to school, and it's, you know, it should not be a barrier to making it to the hike today. But so we saw that the patients that that need to be hospitalized, they will come in no matter how far they have to travel. But for outpatients, we see a pretty strong effect of travel time. The further away you live, the less likely you to come in for your outpatient visit. And so sort of to put this in perspective, the incidence rate of outpatients with major depression, which is our least severe group of patients that we're studying, drops by 22% for each 1 hour increase in travel time. Okay, so yes, travel time is a barrier to seeking care, but it's mediated by disease severity. And travel time is a barrier for mild cases. So Greta Gerdes, who is here, joined my lab, and she says, well, that's very interesting, but it's not really good enough. Like, there could be other things that are barriers to seeking care. And also, one of the things that she was interested in is measuring different way of looking at severity. Like here we used hospitalization versus not, but you could look at all kinds of dimension of severity, like is somebody psychotic, is somebody suicidal, etc. And so this was something that she took on. Not just in the initial project, we focused on the first visit. And one of the things that she was also interested in is what happens after the first visit. Like, do people continue to seek care, and is the overall rate of seeking care affected? Okay, so here's like the kind of model. It's a negative binomial count model where we're looking at different outcomes, which are listed here, 7 different outcomes, inpatient visits, ER visits, and we're looking at the rate of observing, let's say, delusions in the clinical notes for these patients. And what we find is this. We see some very similar results. We're consistent with our original findings using a slightly different model, that people that have to travel further more frequently relative to the total number of visits are being hospitalized. So they're more severe when they come in. They also have more delusions, more hallucinations, and we don't see an effect for suicidality. So we don't see a travel time effect for suicidality. We also observe that patients coming into the ER actually live much closer. So the ER only serves people that live basically within 30 minutes of the hospital. So the next question that we wanted to ask is socioeconomic status a barrier to treatment? Because maybe if you live 5 hours away, it matters, what your means are. And so to study that, we use insurance regime as a proxy for socioeconomic status. And to understand that we can do that, you need a little bit of knowledge about Colombia and their insurance system, because Colombia has, as of 1993, universal health care. And so everybody has health care. Right now it's about 90-something%. And whenever you seek care, you're basically automatically enrolled in health care. And there's 2 regimes. 2 most common regimes are one for vulnerable or poor individuals as designated by the government, in which case the state assumes the majority of the cost of the health insurance. And then there is a second group, contributory or non-vulnerable individuals, where the employee pays, when people are employed, and the employee pays part of the health insurance. And so we use these two regimes to have a proxy of socioeconomic status. And what we find is very similar to what we found with travel time, that vulnerable individuals have higher rates of inpatient visits, psychotic features, and also lower rates of suicidal ideation. And in this model, the reference is non-vulnerable. So, more on that side is more for vulnerable individuals. Of course, we put these two things together and we see that they're very similar, like the effect of travel time, the effect of socioeconomic status have very similar patterns. And so the next thing that we did is take one model and account for both. And so here we have the effect of travel time, but now each model has two rows where the bottom row is where we account for socioeconomic status. And what we overall see is that if we take a model of travel time and correct for patients' socioeconomic status, much of the effect sort of goes away. The opposite is not true. If we take socioeconomic status and correct for travel time, the results are very, very similar. And then we finally looked at an interaction, and we see that the effect of travel time on severe outcomes is strongest in vulnerable groups, particularly for the inpatient visits. Okay, so back to our goals. Mission origin participants are broadly representative of those receiving care in the region or in the hospital. The hospital cares for everybody that needs to be hospitalized, but travel time and lower socioeconomic status, especially the latter, are barriers to seeking care, even in a country with universal health care. And one other thing that we see is, and that we're interested in studying further, is that patients with lower socioeconomic status really tend to miss a proportion of their outpatient visits. And what effect that has on their long-term outcome is something that we're interested in studying. So we're excited about Mission Origin. It will be one of the largest genetic studies of severe mental illness in the world. It will be the first biobank in South America. It will be well-powered and minimally biased. Of course, every project has bias. And we believe it will advance the goal of precision medicine and increased health equity. It's going well. We're currently at 75,000 participants. We have less than 1 year left of recruitment. Here was a party that we had when we hit 50,000. We have so far sequenced 30,000 individuals using blended genome exome product, and more is being sequenced all the time. We expect another 30,000 by the end of this calendar year. We're starting to do, I don't really have genetic results, but we're starting to look at initial genetics. For example, admixture profiles in the region. These individuals are all admixed, primarily European and Native American ancestry, with some African ancestry. And here, for example, a rotation student, Ravi, did this where he looked at IBD segments, which is also something that Jaslyn originally looked at in this region. And we are looking here at how much IBD sharing there is between individuals living in the same municipality. And these are all the municipalities that we so far have data on. So we're beginning to look at these data. Okay, good. Back to Atlas, right? Remember that problem that we sort of stopped at. So the question, are Atlas participants representative of those receiving care at UCLA? And this is work led by Aditya Pimplaskar, which he does together with Joanne Q, who is going to start the PhD program in biomath here in the fall. So we looked at a bunch of features initially, sort of just to kind of figure it out for ourselves, and we found that there's a higher proportion of individuals in Atlas compared to UCLA EHR who self-identify as white, who have private insurance, who have UCLA primary care and who are older. And so we were thinking, well, let's model actually whether we can use your EHR to predict whether you're in Atlas, yes or no. And so we used all these features, demographic information, diagnostic information, including several access to care and vulnerability scores that are computed for all patients in our EHR. And so what it turns out, we can really well distinguish people that are in Atlas from those that are not using their EHR. We can predict participation accurately with an area under the ROC curve of 0.85, and this is I believe this is a random forest model, but it doesn't really matter so much what model you use. So Atlas participants are not quite representative of UCLA patients. As I said already, some of here are the most important Shapley values. Being a primary care patient at UCLA is one of the most predictive features. We also tried to whittle down. Initially, I think we started with 180 features, and we thought, how small can the model get for it to be still successful? And it turns out that with just 5 features, age being primary care, number of encounters per year, SVI, Social Vulnerability Index, as well as BAS, which is a barrier to accessing service index, together achieve an area under the ROC curve of 0.83. So that's bad, or that's a fact, regardless of how you feel about it. But one thing that we're currently working on is seeing whether we can use these probabilities to sort of mitigate the participation bias and account for it in our genetic analysis. And so that is very much ongoing, and I'm going to mention it here because you guys might have some ideas for us. But what we can do is take your probability of being included and inverse weight those individuals in our genetic study. So somebody that was in Atlas but is actually very unlikely to be in Atlas based on their profile gets upweighted in our genetic analysis, and the reverse for people that are very likely to participate. And so we're starting to do this. We're not quite sure how, but here, for example, we use a bunch of polygenic risk scores available to a polygenic risk score library. And we use, in this case, outcome of MDD, but we're also using much more standard as well as quantitative phenotypes. And we're seeing how does the estimate of how this polygenic risk score predicts, in this case MDD, affect whether we're using the weighted or unweighted genetic analysis. And we see there are some differences, but there's also similarities, and we're trying to quantify this to really get to the bottom of how much this participation bias actually affects our genetic analysis. Because thinking back about these guys, right, the women that were pregnant with depression and the women that were never pregnant with depression, or I shouldn't say that, the women that might have been pregnant but got depression outside of the postpartum depression window. So we're like, how does this initial thing that we saw, right, that the MDD cases had a higher polygenic risk score, how is that actually affected if we now reweight participants based on their likelihood of being in Atlas? And it turns out, this is actually funny, Aditya and I were talking about this yesterday, it turns out that if we reweight, if in our weighted analysis, the effects get even stronger. So I thought that it would go away. I thought it was part of this bias, but it doesn't go away, it gets stronger. So yeah, stay tuned for us to figure all of this out. Conclusions, Atlas is not yet a representative of UCLA. We've shared these results with the people in Atlas, and it might affect some of the recruitment strategies, but we can study and hopefully account for ascertainment bias. So stay tuned for that. yeah, here's just some messages now that are coming. So being aware of bias and representation is helpful, even if that's not what you're studying. Like even if you're studying lipids, being aware of this will help you at least be cautious in interpreting your results. Another thing that I want to mention, especially to the audience like this that often starts when the data is already there, recruitment is effort. It's an incredible effort, and it's really important to be aware of. This picture on the left, I always ask people, what do you think this is? And if you know it, you cannot answer, but any guesses?
Paper?
Paper, yeah.
Unused surveys or something or other like that?
Yeah, so these are consent forms for our studies in Colombia. We cannot, for various reasons, do electronic consent. So that's just like a tiny little thing that you don't even think about how that gets organized. And there's a huge team working every day to make this database that we're creating for the scientific community as good as we can have it. So be aware of that when you just throw out, 12% of your sample because something is maybe not the way you expected it to be. I started with this title, using biobanks to study people that are not in it. That's, of course, a completely ridiculous title. But instead, I would like to say use biobanks, but be aware of people that are not in it. And so with that, I would like to thank all our collaborators here, as well as in Colombia and in our other projects that I haven't talked about today in Brazil, my lab, especially Aditya and Greta, who've done most of the work that I talked about today. Nelson Freimer and Carlos Lopez Jaramillo are my closest collaborators in the Mission Origin project, as well as my funding. So thank you.